Good morning, everyone. Today, we're very grateful to have a guest speaker, Dr. Adrian Lee, with us. Dr. Lee is a clinical associate professor in the Department of Medicine at the University of Calgary in the Division of Hematology and Hematologic Malignancies. She works at the Foothills Hospital, and she works with the Southern Alberta Rare Blood and Bleeding Disorders Comprehensive Care Program. She is active in research for hemophilia and hemostasis thrombosis and has a number of projects with trauma surgery, obstetrical medicine, and anesthesiology. Please welcome Dr. Lee.
Thanks, Anita, for that introduction, and thanks everyone for inviting me to talk to you about bleeding disorders and specifically case presentations that might present in the emergency department and emergency management of bleeding disorder patients. Some of you may have attended the CAPE symposium a couple years ago where Dr. Lang and I actually did a similar kind of presentation. So I apologize if some of the cases overlap and you've seen some of these cases before, but hopefully it's still a good reminder of how to manage bleeding disorders. So these are my disclosures. And so the objectives for today are basically to go through 3 cases to review unexplained bleeding and bleeding disorder management. And then briefly at the end, I would like to give you a plug on the overview of our comprehensive care program and the services that we provide and how you can get a hold of us. So we'll start with patient case number 1. So this is a 76-year-old gentleman with a history of paroxysmal atrial fibrillation. He's on just aspirin for this and had a prior history of prostate cancer that was diagnosed in 2010. So he comes to the emergency department as his first visit, presenting with left calf pain, swelling, and bruising. And the initial assessment was, oh, maybe this is a DVT or a Baker's cyst that's ruptured, and some bruising related more from being on aspirin. So he goes on to have an ultrasound Doppler that shows no evidence of a DVT, but this complex collection that the radiologist mentioned, oh, it looks like it could be a ruptured Baker's cyst or a loculated abscess. So he's given some antibiotics and sent home and instructed to return to come to the emergency department if his symptoms, worsen. So a few days later, he has increasing calf pain and developed some presyncopal symptoms. So came back to the emergency department, and an ultrasound guided aspiration actually just showed frank blood, and it turned out this was a loculated hematoma. So he's basically been bleeding into this calf for about a week or so. So just taking a step back, this is one way I like to sort of think about the differential diagnosis for common bleeding disorders. I do like to separate things into platelet problems, so thrombocytopenia, platelet dysfunction, whether it be congenital or acquired related to medications, and then inherited coagulation disorders. So that's typically anything that might be involved in the coagulation cascade that can result in an abnormal PT or PTT. So things like Hemophilia A, Hemophilia B, von Willebrand's disease, other clotting factor deficiencies. And then acquired coagulation disorders, which are probably going to be the most common that you'll see in the emergency department. So obviously patients on medications like warfarin, direct thrombin inhibitors, other anticoagulants, if they have vitamin K deficiency, liver disease, DIC, or in rare cases, develop acquired factor inhibitors. So going back to the case, this was his blood work. So when he if you go back in NetCare, you can see that he had some blood work done 4 years prior, had a normal hemoglobin at that point, had a normal INR of 0.9 and a normal PTT of 28.1 seconds. When he came into the emergency department, his hemoglobin was 92, his platelet count was normal at 434, and I'm not sure exactly why all the coag parameters were done, probably because there was some bruising at that site. So he had an INR and PTT done, and that PTT was prolonged, but I guess no one really thought much of it, and he was just sent home on those antibiotics. When he came in for his second visit, he had a hemoglobin of 68, so he had bled clearly. INR was still normal, and his PTT was still elevated at 96.5 seconds. And it was the day after that he had the aspiration of his cyst after receiving a red cell transfusion. And again, his PTT is prolonged, 103 seconds. So Anita asked me to just put this in. I usually try not to talk about the coagulation cascade because I find people's eyes glaze over and brings them back to medical school. But it's good to at least have a basic understanding of how to interpret PTT and PT prolongation, and that requires some knowledge of the coagulation cascade. So it's important to know that this classical representation of the coagulation cascade is not what is happening in vivo. Within our circulation, there's a lot more crosstalk between the extrinsic and the intrinsic pathway. For example, tissue factor and factor 7A, once it's activated, does crosstalk and activate factor 11 in the intrinsic pathway, so it's all connected. However, the reason why we separate this is that it allows us to measure clinically important parameters to help us with diagnosis or monitoring of anticoagulation like warfarin. So as we know, the PTT involves the contact factors, which are high molecular weight kininogen, prekallikrein, and factor 12. And that in turn, inside the test tube, with the addition of a negatively charged surface like silica, ellagic acid, or kaolin, will then activate factor 11, which activates factor 9, which activates factor 8, which is then the cofactor for factor 10 in combination with factor 5 to create the prothrombinase complex, which converts prothrombin to thrombin, which is our ultimate goal. We want to have a lot of thrombin around if we want to clot something. And that thrombin then converts fibrinogen to fibrin, which is your final product. On the extrinsic side, which is measured by the PT or the INR, it is in the test tube, it's activated by the addition of tissue factor. And then in the presence of factor 7A, this combines to then also activate factor 10 to 10A, which with its cofactors factor 8 and factor 5 then convert prothrombin to thrombin and then creates your final product, fibrin. So abnormalities in the PTT only typically is due to deficiencies or problems with factor 11, 9, or 8. Of course, you can have also deficiencies in your contact factors, which are 12, HMWK, and prekallikrein, but those are needed for intrinsic pathway activation inside the test tube, in vitro, not in circulation. So you might measure a prolonged PTT, but these patients actually have no bleeding symptoms at all. On the other side, the INR, if you just have a prolonged INR, typically this is due to factor 7 deficiency. But remember that all of these things can merge into the common pathway. So you can see with severe deficiencies, elevations in both PTT and INR. So that's something to be aware of. So moving back to the case, this is a situation of an isolated prolonged PTT. So we don't have, it doesn't look like any of the extrinsic pathways involved. We would expect that this patient's factor 7 levels would be normal. So I like to separate this into thinking about deficiency and inhibitor. And if we look at deficiency, I then clinically decide if this patient is presenting with bleeding or if they're not bleeding. If they're bleeding, then deficiencies that could cause bleeding are factor 11, 8, and 9. And if they're not bleeding, you can have a prolonged PTT due to deficiencies in your contact factors and factor 12 that simply results in a prolonged PTT in vitro, but not result in any clinical bleeding. When we come to the inhibitor side, there's sort of two main categories I like to think about. So development of antibodies, or the patient's on some sort of drug that's acting as an inhibitor against the PTT clotting factors. Again, with antibodies, I then separate the patients into, are they presenting with bleeding symptoms or are they not bleeding? And if they're not bleeding, that usually leads you to something like a phospholipid, an antiphospholipid, or a lupus anticoagulant. Whereas if they are bleeding, they may have developed an acquired inhibitor against factor 8 or factor 9. Drugs are probably your most common cause for PTT, and so obviously heparin contamination, if you take it off, a central line, or the patient's on heparin, they're on a direct thrombin inhibitor like argatroban or dabigatran. Direct 10A inhibitors can also prolong your PTT, but probably to a lesser extent than DTIs. So now we're going to talk about what's the next step in trying to work up prolonged PTT, because ultimately you need to figure out, does this patient have an inhibitor or does this patient have a factor deficiency? So what you're going to order here is a mixing study. And you may remember from medical school, mixing study is basically a one-to-one mix of patient plasma with normal plasma. So normal plasma should have all your clotting factors present, so they should have a normal PTT. The patient's plasma obviously is either deficient in the clotting factor or has an inhibitor or antibody against the clotting factors. So if you mix a patient who's deficient in clotting factors, and that's the bottom 3 tubes you'll see there. So they're missing clotting factor, you add normal plasma, so you're replacing or giving additional clotting factor, then you should be able to correct the PTT once it's mixed together. However, on the upper 3 tubes, you can see if the patient has an inhibitor or antibodies that bind and inhibit the activity of the clotting factor, it doesn't matter if you're adding more clotting factor to it from the normal plasma. Those antibodies are present, binds up and inhibits the activity of the clotting factor. So the mixture, the PTT in that mixed tube, remains prolonged. The second step is to consider measuring the intrinsic pathway factor levels. And so these are factor 11, 9, and 8. And typically you don't have to do this if you're highly suspecting a lupus inhibitor and the patient isn't bleeding. But obviously if the patient is presenting with bruising and bleeding symptoms, it's important to measure these levels because you want to know which factor is deficient or being inhibited. So going back to the case, this is the mixing study that was done. So the patient sample PTT was prolonged at 106 seconds. The control or the normal plasma PTT, as you can see, is normal, 25 seconds. When they did the one-to-one mix, the PTT was still prolonged at 101 seconds. So because it does not correct, that means an inhibitor is present. And when you go on and measure the clotting factor levels, we see that the factor 8 level is very low at 1%, and there's an inhibitor present at 152 Bethesda units. So this patient had acquired hemophilia A. This is a bleeding disorder caused by an autoantibody to factor 8. It's a rare disorder. The incidence is somewhere around 1.5 per million per year. At the foothills, we get all the referrals for acquired hemophilia A. We, on average, are getting anywhere from 3 to 8 cases per year. It mainly affects older patients, and it can be associated with other underlying conditions like autoimmune diseases, malignancy, drugs, skin conditions, especially pemphigus, and there are cases of pregnancy or postpartum associated acquired hemophilia A. Bleeding can be anywhere from life-threatening to mild, and these patients obviously should have no personal or family history of bleeding. The mortality is generally quite high, between 8 to 22%, and the death is not always from bleeding, although can be. Oftentimes death or mortality is related to complications related to the immunosuppression. The bleeding phenotype is also distinctly different from congenital hemophilia. As you know, severe hemophilia patients tend to have deep muscle or joint bleeds. Acquired hemophilia, on the other hand, is mainly mucocutaneous, often soft tissue, muscle, and GI-GU. So these are some pictures of patients with acquired hemophilia. These are very typical presentations. You can see in figure A, that was where a blood pressure cuff was. And these patients can develop very extensive bruising. They are at risk of developing compartment syndrome if there's significant bleeding into a compartment. So that's something also to be aware of and to think about. The diagnosis is often delayed because the patients may, typically don't have a prior history of bleeding, and their first presentation to emerge or their primary care physician may be that of just bruising. And it's, as I mentioned, a rare disorder, and it's not something that even most hematologists are comfortable with treating. So delayed diagnosis does result in suboptimal treatment and bleeding complications. So the key is to try and order a mixing study looking for the inhibitor in order to make the diagnosis as quickly as possible so that management can take place. The key that I always tell people, whenever they see a prolonged PTT, always think about why is that PTT prolonged. If the patient is on a drug or on heparin, or potentially there was heparin contamination, then of course the PTT is prolonged. You don't need to go down the road of ordering a mixing study and hemostasis studies. If the patient has a known lupus inhibitor, there's no reason why you need to investigate it. However, if this is new, and even if the patient isn't bleeding yet, it's important to at least repeat the PTT and order the appropriate mixing study and clotting factors as necessary. So I will very briefly mention how acquired hemophilia is treated. The management is mainly twofold. We need to treat and stop the active bleeding, and then we also need to eradicate the inhibitor. For acute bleeding, there's sort of three ways that we go about doing this. One way is to try and overwhelm the inhibitor by giving them lots and lots of factor VIII concentrate, so higher doses than what we would give to a regular severe hemophilia A patient. This only works if the inhibitor is at low titer, and low titer means less than 5 Bethesda units. So for this patient, it wouldn't have worked. The other way that we most commonly use is bypassing the factor VIII step in the clotting cascade. So that's using something like niastase or recombinant factor 7A, or factor VIII inhibitor bypass activity concentrate, FIBA, which is also known as activated prothrombin complex concentrate. And then finally, there is, this is a fairly new product. It is available now through our transfusion medicine blood bank. This is recombinant porcine factor 8 concentrate. And basically, because it's porcine factor 8, there's very little cross-reactivity with the human anti-factor VIII inhibitor. So you're actually able to overwhelm the inhibitor and increment their factor VIII levels to a measurable level. The problem with bypass inhibitors is that because it basically bypasses the factor VIII step, you will still have very low factor VIII levels if you measured it. So you can never know if you're achieving adequate hemostasis based on PTT results or factor VIII levels. It's all clinical evaluation of whether the bleeding stops with these bypass agents. To eradicate the inhibitor, we give immunosuppressive therapy. Typically, this is steroids plus minus cyclophosphamide or rituximab. At the foothills, we are trying to use rituximab more upfront because there's less infectious complications related to it, but cyclophosphamide is also commonly used in other centers. And it's important to know that as long as that inhibitor remains present, the patient remains at serious bleeding risk. And basically, you're converting this previously normal patient to a hemophilia patient. And there's a lot of education that has to go into this because patients forget that they actually have a propensity for bleeding. So that was case 1. I'm going to try and quickly move on to case 2. So this is a 21-year-old woman who presents with severe headache, neck stiffness, photophobia, and fever. She's assessed by the emergency physician, and they are concerned for meningitis and would like to perform a lumbar puncture. The patient tells the doctor that she has von Willebrand's disease, but it's been a long time since she's been seen by her hematologist, and she doesn't know what kind of VWD she has or what her treatment should be. She's never actually received DDAVP and doesn't know if she responds to it. She also forgot her emergency treatment card, which she's supposed to bring with her, and she's from out of town, so no one at our hemophilia center knows her or is aware of what her diagnosis is. So her initial blood work shows a normal hemoglobin, normal platelet count, her white cell count is slightly elevated, her INR is normal, and her PTT is just slightly prolonged at 39 seconds. So what do you do in this situation? So just a quick overview of what von Willebrand factor does. Von Willebrand factor is made and stored in our vessel endothelial cells and can be released in the setting of stress or when required for injury-associated hemostasis. It is a very large multimeric glycoprotein, and it has 2 main roles. So it's involved in platelet adhesion and aggregation, so to form that primary platelet plug. So I consider it kind of like the first responder to vascular injury. It goes there, the platelets aggregate and adhere and try and plug off wherever the bleeding site is. Von Willebrand factor also is a chaperone of factor VIII, so it protects factor VIII from rapid clearance from our circulation, and therefore is also involved in secondary hemostasis. So that's clotting cascade related hemostasis, what's needed to make that final fibrin that secures the platelet clot. So you need both of these in order to stop bleeding. Von Willebrand's disease is the most common congenital bleeding disorder. And the symptoms can vary depending on the severity and the type of von Willebrand's disease. Most commonly, VWD, because it affects primary hemostasis, results in mucocutaneous type bleeding, so epistaxis, gingival bleeding, uterine bleeding, postpartum bleeding, bleeding with invasive procedures. And von Willebrand disease, I'm not going to go into too much detail, but just so that you remember, there are 3 types. There's type 1, type 2, and type 3. Type 1 is a purely quantitative deficiency in von Willebrand factor levels, where both the antigen, which is the protein, and the activity of von Willebrand factor are similarly decreased. And I would say the majority, like 75 to 80% of type 1 VWD will respond to DDAVP. Type 2 involves various subcategories, but it is the result of a qualitative defect in von Willebrand factor, where the activity level is much lower than the antigen or the protein level. These patients can be responsive to DDAVP, but oftentimes it may not be adequate for severe bleeding, and there are some types of type 2 VWD where DDAVP is contraindicated. And then in type 3, there's the complete absence of von Willebrand factor. So basically, they make no VWF protein. There's nothing stored in their endothelial cells. So it doesn't matter how much we try and stimulate it with DDAVP, they will never have a response. So target pre-procedural levels for invasive procedures will vary depending on the extensiveness or the invasiveness of the procedure. So major surgery, if the patient needed like emergent intra-abdominal surgery or orthopedic surgery, we are targeting von Willebrand factor and factor VIII levels of 100%. Minor procedures like dental extractions, skin biopsies, usually a target of somewhere between 30 to 50% is sufficient. For lumbar puncture and neuraxial analgesia, we do target a level of 50% or higher just because it is in a tight space and the risk of epidural hematoma obviously has severe morbidity consequences or morbidity consequences. So the general rule of thumb for all bleeding disorders hemophilia, von Willebrand factor, any sort of clotting factor deficiency is basically to replace with the factor concentrate for which the patient is deficient. So in von Willebrand's disease, we want to replace the missing factor, which is von Willebrand factor. So to do this, there's two main ways. We have two main treatment options. One increases the endogenous von Willebrand factor levels, and the second basically just replaces the deficient factor. So DDAVP is what stimulates this release of endogenous von Willebrand factor from the endothelial cells. As I mentioned, it's the most effective common treatment in type 1 and some type 2 von Willebrand disease patients. However, in order for us to be confident that DDAVP is going to work for these patients, they do go through a challenge test with DDAVP to make sure they have an adequate increment in their von Willebrand factor levels. About 15 to 20% of type 1 will not have an adequate response to DDAVP. DDAVP can be given IV, sub-Q, or intranasally. And then in terms of replacing von Willebrand factor, we give them von Willebrand factor concentrate. This is different from factor VIII concentrate, although that's often what it says on the box. You just have to make sure that it contains both von Willebrand factor and factor VIII. The most common products that we have in blood bank are Hemophilia A and Willebrand. And this is typically the treatment used for type 3 and some type 2 von Willebrand disease patients. So when in doubt, if we don't know if the patient is responsive to DDAVP, or we don't know what type of von Willebrand's disease they have, the best thing to do is just give von Willebrand factor concentrate, especially if you're doing a risky procedure like a lumbar puncture. So this patient basically ended up getting Hemophilia A, and 30 minutes after the administration, you can go ahead and do your invasive procedure or the lumbar puncture. I'm just going to review a few von Willebrand disease clinical pearls. So DDAVP, just to be aware, can cause symptomatic hyponatremia and seizures, especially at the extremes of age, so very young children and the elderly. We do recommend in older patients that electrolytes be monitored, especially if you're giving repeated doses of DDAVP, and to try and fluid restrict these patients to less than 1.5 liters for 24 hours after DDAVP is given. Tachyphylaxis can occur with repeated DDAVP doses, especially if they're given in very short intervals, so less than 24 hours between doses, and especially after 2 or more consecutive doses have been given. So after two or more doses have been given, there's not a huge increment on in your von Willebrand factor levels anymore, and at that point, hematology should be consulted if they're still bleeding despite DDAVP. Use of antifibrinolytics like tranexamic acid can be given as an adjunct or alone in von Willebrand disease, depending on the severity of bleeding and the severity of their disease. However, we should always avoid antifibrinolytics if they have hematuria, because this can result in clots within the ureteric system and cause obstructive uropathy and renal failure. DDAVP is often given subcutaneously, can also be given intravenously. It's dosed at 0.3 micrograms per kilogram. It can also be administered intranasally, but the important thing to note is that this dose is much higher than the dose given for enuresis, and the enuresis doses that we give to children is not effective. So just be aware of that. And how fast does DDAVP or clotting factor work? Pretty much immediately, but generally we recommend doing your procedure about 30 minutes after the DDAVP or von Willebrand factor is given, so that you're at the peak doses, the peak levels. So I'm doing pretty good for time here. I just want to leave time for questions. So this is patient case 3. This is a 23-year-old male who presents with right-sided abdominal and groin pain. It started several hours after he was jumping on a trampoline with his friends, and he tells you he has hemophilia B up front. So he's got a low-grade temperature, a pulse of 115, blood pressure's 110 on 65, and oxygen saturations are pretty good on room air. He's extremely uncomfortable when you try and examine him. He's not able to stand up or lie completely flat on the exam bed. He's reporting some pins and needles sensation to his anterolateral right thigh. He's got guarding on abdominal palpation. There's no mass palpable. You don't note any swelling, warmth, or bruising over the abdomen or groin. His baseline blood work shows a hemoglobin of 117, his white cells slightly elevated, electrolytes and platelets are normal, his PTT is as is expected, prolonged at 76 seconds, INR is normal. So possibilities as to what's going on, young guy presenting with, right lower quadrant groin pain, could be a number of things. However, in a hemophilia, severe hemophilia patient, we have to think about iliopsoas bleeds. It's an uncommon muscle bleed, but can occur with overuse or hyperextension injury to the iliopsoas muscle in hemophilia patients. So what do you want to do? Obviously, we are going to have to do some imaging, but the correct answer is to treat him first. When there is ever a hemophilia patient presenting with, or any bleeding disorder patient presenting with clinical suspicion of a severe or life-threatening bleed, it's always important to give factor first before sending them for diagnostic testing. Where can you find information about his treatment protocol and what dose to give him? So all of these are correct. You can look at their factor first card. So all patients are supposed to be carrying their treatment protocol on a factor first card in their wallet. You can page hematology. You can call our clinic, especially if they say they're a patient of ours. And in Calgary, on SCM, there is a ED treatment protocol for all of our bleeding disorder patients, and this is now also available on NetCare. So a few hemophilia basics. As most of you know, it's an X-linked hereditary condition caused by the failure to produce a clotting factor that's involved in the coagulation cascade needed to make that platelet fibrin clot. Males are affected, but females are carriers. It is important to know that females can actually have hemophilia, some of them severe hemophilia, due to severe or extreme lionization, where they actually have low factor 8 or 9 levels. Types of hemophilia include hemophilia A or B. Hemophilia A is the more common one, affects about 1 in 10,000 persons, and there's about 2,500 to 3,000 affected in Canada. Hemophilia B is less common and is a deficiency in factor 9. With hemophilia A and B, the severity is based on the measured clotting factor level. So less than 1% is considered severe, moderate is 1 to 5%, and mild is greater than 5%. And the bleeding severity is highly correlated with the clotting factor level. So severe patients typically present when they're very young with spontaneous bleeding into muscles or joints and require regular prophylaxis. So the treatment goals in hemophilia depend on the severity of the bleeding. So major bleeding, we're targeting, again, levels close to 100%. I've just put down some of the usual doses there. Mild or moderate bleeding, we usually target between 40 to 60%. With hemophilia A, mild hemophilia A can be responsive to DDAVP if they've been tested, and their factor first card should state exactly what you should do. So for this patient, you give him 125 units per kilo of recombinant factor 9 or Benefex, some morphine, and then you send him for a CT scan. And I apologize, this actually happened to one of our patients, but he had an iliopsoas bleed on the left, so you'll see it's not actually on the right side like I said in the case, but he had a left extremely large iliopsoas bleed. So this is a bleed you do not want to miss because it's associated with high morbidity and can be potentially life-threatening. It requires very aggressive treatment and a lot of physiotherapy because of the inflammation that is around that muscle and can result in fibrosis and contracture in the long term. it's also very at high risk of rebleeding because it's a muscle that we're often using. It can be misdiagnosed because it often mimics other types of pain, and usually isn't associated with any bruising or swelling because it's a deep muscle bleed. Initially, you may not see a hemoglobin drop because it's contained within the fascia of that iliopsoas muscle, but as it continues to bleed, oftentimes the hemoglobin can drop quite severely. There are some red flags, and mainly signs and symptoms of neurovascular compression, especially the femoral nerve, and this requires immediate attention. So just a few key points. The Factor First card will tell you the patient's treatment protocol. If it is missing, treatment protocols can be found in neck care, or if you're somewhere else outside of Calgary, there are treatment guidelines available from the CHS, Canadian Hemophilia Society, the World Federation of Hemophilia, and there is a great YouTube video on management of bleeding disorders that was developed by a hemophilia doctor at St. Mike's Hospital. And as I mentioned, when in doubt, always treat first and then give the clinic a call. So that leads me into giving you a brief overview of our clinic. So we are the Southern Alberta Rare Blood and Bleeding Disorders Program. We are the adult bleeding disorder clinic. The children's at ACH have their own hemophilia treatment center, although we do work closely with them, and we have a transition program for adolescents. Our team, we actually have 4 physicians, which we're very lucky to have. I'm sure a lot of you probably know Dr. Poon, who's been around for many, many years and basically founded this program. Myself, Dr. Dawn Goodyear, and Dr. Natalia Ritz also work in this clinic. We have 3 nurses. We're lucky to have a social worker, a dedicated psychologist, physiotherapist, and our data manager. Our census has been increasing quite a bit over recent years. A lot of the increase has been in our sickle cell and thalassemia populations, but you can see we have about 1,000 patients in our clinic. The majority are bleeding disorders. Most of these are not hemophilia patients. Many of them are von Willebrand's disease, platelet function disorders, or undefined bleeding disorders. So at our clinic, we actually have a call rota. Each of us are on call for 1 week a month. And the reason why we do this is that we also provide support to our hematologists who aren't as familiar with our patients. So if you call the clinic and you have a question about a case, one of our patients, or anything related to congenital or acquired bleeding, you can contact the clinic and the nurse or a clerk will direct you to the physician who's on call that week. We do run clinics every 2 weeks, one for hemostasis and HAE, and then a separate one for hemoglobinopathy. And we see our patients anywhere from every 6 to 24 months, depending on their bleeding disorder. Most of our severe patients are on a home infusion program, so they treat at home prophylactically and have very good self-infusion techniques. They all should have treatment first cards, but as I mentioned, they don't always carry it with them. Individualized protocols are available always in their net care notes. So all our notes always at the very top of our dictation, we do state their treatment protocol. But there's also the eMERGE department specific treatment protocol that's available. This is what the Factor First card looks like. You can see at the bottom the recommended treatment for major and minor bleeding episodes, and the contact information is on their card. In Calgary, in SCM, the treatment care plan is available as the ED treatment plan. For rural patients, you can find their treatment protocol on their Factor First card. some of our patients is actually using this MyCBDR app. This is where they record all their treatments and their infusions and bleed records, and their treatment protocol is actually on that app. So you can ask them to pull it up and you can find their protocol there. And since early 2018, this ED care plan is actually on NetCare. So anywhere in the province, you should be able to find the patient's treatment protocol. So where can you find us? We are at the Foothills in the Special Services building. That's our phone number and our fax. Or you can just page one of us if you want to chat or have a question. And that's the end. Oh, I think I did pretty good. I've left a lot of time.
Thanks for the presentation, Adrian. We'll move on to the Q&A here. Question for you, just for one of my own questions is, for your treatment protocols for von Willebrand disease, do you, after giving DDAVP, do you have a statement in there saying like guidelines for fluid restriction for patients?
Yeah, we do. So on the ED treatment protocol, that's always stated as a recommendation if DDAVP is one of their treatment options. And on their Factor First card, we will also write it in there in case they're, the patient's out of the country or in another province. Anyone who looks at the card should have all that information there. We try not to put too much information on their card because then it's just too much to read. But we do state, we do mention the fluid restriction. We have had patients actually seize because of hyponatremia.
Okay. So it's important for us to also remind them.
Yeah, for sure. And we always, whenever it's given, our nurses always remind them, and we ask whoever, a treating physician, if they're giving the DDAVP, to remind the patient they should fluid restrict.
Okay. Okay, Sean Dowling had a question about, for patients with acquired platelet disorders, for example, if they're on Plavix or Ticagrelor, does the timing of the medication influence the decision for performing an invasive procedure? In these patients, should we be treating with DDAVP or von Willebrand factor prior to these procedures?
Yeah, so antiplatelet agents definitely result in that acquired platelet defect, as you mentioned. And I think if an urgent procedure is required, something like aspirin, which irreversibly influences thromboxane A2 secretion, it's going to be in the system for a while. I can't remember exactly the duration of action of ticagrelor and clopidogrel. I think it's much shorter, and maybe 1 or 2 days. But typically, if a patient's coming into emergency, I'm sure they've been taking their medication daily as prescribed. So you're going to have some antiplatelet effect. Again, it depends on what kind of procedure you're doing and how invasive it's going to be. There is some evidence of using DDAVP to overcome the antiplatelet effect. DDAVP doesn't just increase von Willebrand factor levels, it does help improve the platelet subendothelial interaction and has been used in platelet function disorders. The other option is to, especially if it's a very invasive procedure, is to give them a platelet transfusion. Or try and delay the invasive procedure.
Okay. Comment here, when I was in medical school in the 80s, Dr. Poon seemed to be senior. How old is he? He's a rock star?
He is a rock star. He is old, and I'm not going to tell you how old he is.
Good question here. So von Willebrand factor is a blood product, right? So yes. When you administer it, what do you, we need patient consent. So what do you explain to the patient for side effects?
Yeah, okay, so recombinant, so I'm going to go back a little bit. So recombinant factor 8 and factor 9 are, they come from the blood bank, but they technically are not blood products in the sense that it's collected from donor plasma and then purified and concentrated. So any recombinant product has very, very low risk of any transmissible infectious disease. The patients obviously need to be aware or counseled that they are receiving a recombinant replacement factor, and anyone can have an allergy or some sort of reaction, infusion reaction to it. Remember that most of these patients will have received the factor before and will have been seen in a hemophilia treatment center and have this already explained to them. Von Willebrand factor concentrate is a bit different. It is not a recombinant product, so it is made from donor plasma that has been purified and concentrated, lyophilized, and solvent and detergent treated. So basically we've treated it so that the majority of enveloped viruses are eliminated. We haven't seen a case of hepatitis C or B since this type of treatment, viral inactivation, has been in place. However, obviously there is the chance of like prion disease transmission and that sort of thing. So for our patients, before we give them von Willebrand factor concentrate, we do mention this, but the rates are so exceedingly low that you know, really it's generally a non-issue. That's usually the counseling that we give from the treatment center standpoint. Anyone who comes to the emergency who has a treatment protocol, that consent and that has already been explained to them. I don't think that you necessarily need consent to give it, but I don't know the policies. It's probably good to just review with them and have them sign the consent form to say that, yes, we're treating you with factor concentrate. But that's the main difference between the two. So it's not like platelets or plasma or anything else, because they are heat and detergent treated.
Okay. For the patients that we see for bleeding disorder, are we paging, if we have a question or there's someone that comes in with severe bleeding, are we paging the hematologist on call or someone specifically from the bleeding disorder clinic?
So if you page the hematologist on call, that's probably the fastest way to get a hold of someone. The hematologists, I mean, we're a close group. If you get someone who is not one of the bleeding disorders doctor, invariably that hematologist will be texting one of us anyway. So you can either call the clinic directly and they'll let you know who's on call for the clinic, or page the hematologist and they will let you know who to contact, especially if it's a complex case. Mm-hmm. So basically just call hematology, anyone from hematology, and you'll get help.
Okay, and if this is something that occurs overnight, then what would be the process of this?
It's still calling the hematologist on call. And they always will be contacting one of us very early in the morning if it's a serious bleed.
Okay. Aaron Johnson made a comment here. Takeda Canada has done a lot of education marketing to Canadian emergency physicians about acquired hemophilia, suggesting that it is under-recognized and easily overlooked. Is this actually something we're missing, or is it just marketing?
It's a good question. I think I can tell you for sure that we're seeing an increasing number of acquired hemophilia cases, and I don't know if that's related to, you know, more of an aging population or potentially increased awareness and diagnosis. It is something that is missed, and I bet you that rate that I quoted to you is higher than it actually is, because there are cases that go unidentified. It is a serious bleeding disorder because, as I mentioned, as long as that inhibitor's around, they are at risk of bleeding. And oftentimes these patients don't bleed until something is done to them. They have some sort of invasive procedure. They had a PTT that was prolonged, you know, a couple weeks or maybe even a few months ago, that went undiagnosed. So I guess to answer the question, part of it is definitely marketing, because they have a product that is used as a bypass agent, and they want you to use it. But I do think that it is an easily overlooked bleeding disorder, because it can just show up in someone who's never had bleeding before, and then they end up with serious bleeding. So we've had two patients in the last 4 months hospitalized with overt GI bleeding, and one patient with extensive subcutaneous bleeding, and was in hospital for a couple weeks because they had an invasive procedure done despite a prolonged PTT, and they didn't know it was an inhibitor.
Okay. We just wanted to just go back to the question about if we're performing a lumbar puncture on someone for query meningitis, for example.
Yep.
And they're on an antiplatelet medication, should we be giving platelet transfusion before this procedure or DDAVP?
So my opinion is no. I don't think that, I mean, I think that if you're going to do an LP on someone who's either on an antiplatelet agent or maybe has a mild platelet dysfunction, it really depends on your confidence in doing the lumbar puncture. I definitely would not be allowing a trainee to do it, and you know the urgency of the procedure, right? So it's so hard to say, because I don't want to say yes, all these patients should get DDAVP and a platelet transfusion. I think blood bank would give me a hard time if we start giving platelet transfusions to every ASA patient who needed a lumbar puncture. The likelihood that you're going to have an epidural hematoma is pretty low, because remember that these patients may be on aspirin probably because of previous thrombotic or prothrombotic complications, right? So they should have normal clotting factor levels. Our hemostasis system is very redundant, so even if your platelets aren't working great, they should still be enough clotting factor and von Willebrand factor around for them to adhere somewhat to the subendothelium if a vessel is severed, right? So I don't have a great answer for that. It's often hard, you know, when in doubt in a proven congenital bleeding disorder patient, it's never wrong to give them their treatment. Acquired causes, in terms of being on aspirin or clopidogrel, those to me are harder, because the degree of platelet dysfunction is probably not the same. So I don't know if that's a very helpful answer. That's sort of neither here or there. My feeling is a proven bleeding disorder, congenital deficiency, if you're going to do invasive procedure, then follow the protocol. But if it's like aspirin related, then you know if you can delay the procedure, then yes. If it's absolutely required, then you know, it really depends on how confident your technique is, how comfortable, you know, our anesthesiologists, like, they all have different practices with this too. I've had anesthesiologists just go ahead and do epidurals in mild von Willebrand's disease without giving them anything, and others who are very worried about the risk of epidural hematoma, although, you know, the case reports of it are generally quite rare.
Yeah, doesn't sound like there's a straightforward answer here, and it also depends
No.
on who's performing it.
Yep.
Yeah. Okay. Another question that popped up was, what about for the patient who has an intracranial hemorrhage or severe life-threatening bleed on antiplatelet therapy?
Yeah. So in that situation, you know, it's surprising. We don't actually get called about that very much, but you know, I think if they are on an antiplatelet agent and they've got a severe life-threatening intracranial bleed, you would be giving them a platelet transfusion.
Okay. Yeah. And then is there a role for a DDAVP?
Yeah, don't know. There's no good studies to say that DDAVP is as effective as, say, platelet transfusion of functional platelets. But like I mentioned, DDAVP does increase that platelet subendothelial interaction and can cause a clinical decrease in bleeding. So probably wouldn't do it in an intracranial hemorrhage just because I'd be less confident about how effective it is, as well as, changes in intracranial pressure and, hypertonic, I mean, the things that you might need to do in that situation probably preclude giving DDAVP. So I would probably err on the side of platelet transfusion.
Okay. Next question is, what are the indications for ordering a PTT? For example, should we be routinely getting a PTT if we're performing an invasive procedure? We often don't order it before doing something like this.
Yeah, I mean, I don't advocate for regular ordering a PTT in the absence of any bleeding symptoms, right? I mean, it does make it hard in those acquired cases, and obviously I have a bit of a bias because that's what we end up seeing. That's what's referred to us. So, I mean, if in a patient who just presents with meningitis symptoms and needs an LP and doesn't have any prior bleeding history or isn't on any anticoagulant or antiplatelet agents, then I wouldn't order it. I would only order the PTT if yeah, honestly, if they are presenting with a bleeding concern.
Okay, got it. What about DDAVP in the dialysis patient with uremia-induced platelet dysfunction and major bleeding?
Yep. So it definitely has been given for uremic platelets. The effectiveness, again, is, there's no good studies. All of it is case cohort studies, and it does seem to help in some patients, but again, if it's very brisk bleeding or life-threatening bleeding in a dialysis patient, I would be giving platelets. Okay.
Platelets instead of DDAVP.
Yeah, I mean, if it's for example, say it's just for an invasive procedure, like, they need a kidney biopsy, you could give the DDAVP, go ahead, do the procedure, and then monitor for any signs or symptoms of bleeding, and if so, then give a dose of platelets. I mean, oftentimes in these cases, we're involved in trying to give guidance case by case and based on the risk of the procedure. DDAVP generally can be tried and is effective, but not in all cases. And we don't know for sure in uremic platelets whether DDAVP is effective enough, depending on the type of procedure.
Okay. Okay. Dr. Lee, I really wanted to thank you on behalf of the Department of Emergency Medicine for speaking to us today. And there's been some really awesome learning points from your presentation here. So thank you so much for joining us.
You're welcome, and thank you for having me.